Good morning. Let us to speak today about the sodium glucose cotransporter 2 inhibitors as one of the newly introduced anti-diabetic drugs. I'll start with introduction, then the pharmacology of this class of drugs, and I'll explain the mechanism of action, and I'll discuss the advantages from the nephrology, from metabolic and general aspects, cardiovascular system advantages, and then I'll go to one of the most important sectors within this presentation, which is concerns and cautions and contraindications for the use of this class. And I'll end with a conclusion. To start with, hyperfiltration is there in the early diabetes. What's meant by hyperfiltration? Hyperfiltration means kidney increases its work to the maximal. So if this is a basal situation, GFR is 120 ml per minute, kidney can increase this GFR up to 180. So this is hyperfiltration, to use the maximum renal function reserve. Hyperfiltration is present in within this range in type 1 diabetes from 10% to 67%, and from 6 to 73% in type 2 diabetes. After a period of time, the functional reserve of the kidney declines. So although here GFR is still 120 ml per minute, but what happened here? The functional or functioning nephron mass declined to 50%. So this is the issue of hyperfiltration. So if we can work early and to target hyperfiltration, we can preserve the renal functional reserve of the kidney. So what is the mechanism behind hyperfiltration? The mechanism is through increasing glomerular pressure, hydrostatic pressure. How this pressure increases? By increasing blood coming through the afferent arteriole. This means afferent vasodilation, and increasing the pressure and resistance within efferent arteriole. So what causes afferent vasodilation are factors in the vascular and tubular signals. So vascular factors include nitric oxide bioavailability, COX-2 prostanoids, kallikrein kinase system, atrial natriuretic peptide, angiotensinogen 1 to 7, hyperinsulinemia per se, or tubular signal through inhibition of tubuloglomerular feedback through macula dense signals. And I'll explain tubuloglomerular feedback within the mechanism of action of this class of drugs. So all these factors lead to afferent vasodilation. The second component of the etiology of increasing hydrostatic pressure is efferent vasoconstriction. So factors causing a net increase in efferent arterial resistance, this means efferent vasoconstriction, are through vascular factors: angiotensin 2, thromboxane A2, endothelin 1A receptor, reactive oxygen species. So both factors that increase afferent vasodilation and efferent vasoconstriction, at the end, all these factors can lead to glomerular hyperfiltration. What about the pharmacology of this class of drugs? So then every day we can find newcomers to the class of sodium glucose cotransporter 2 inhibitors. So this is a list: canagliflozin, Invokana, in a doses 100 and 300 milligram, dapagliflozin for SIGA 5 and 10 milligram, empagliflozin 10 to and 25 milligram, and any of these drugs with combinations, metformin with DPP4 inhibitors, and other members like epagliflozin, tofagliflozin, and others. If we look at this letter A, this means that the drug is FDA approved and approved within European medical countries, European Medical Agency approved. So this is all A letters are approved, are drugs, are referring to drugs approved within the United States and Europe. Regarding B and C, B means Ministry of Health and Welfare approved in Japan. C means it's still under clinical trial and waiting approval. So this is the names of the drugs within the class of sodium glucose cotransporter 2 inhibitors. What about pharmacokinetics? This table summarizes the different pharmacokinetics domains: bioavailability, metabolism, elimination pathway, and approval. As you see here, this drug is approved within 40 countries, including European Union, USA, and Japan. Here the same 40 countries, including European Union, USA, China, and Russia. And this is FDA approved, and this is the drug is approved in Japan. You can fix the slide to look at metabolism, elimination, and other factors, therapeutic dose, etc. Another table shows the name of the drugs, the manufacturer, and the status of approval, and the dosage for each drug. And here you will find selectivity for sodium glucose cotransporter 2 and sodium glucose cotransporter 1. So you can here find the variability within different drugs regarding this selectivity. And the half-life. Half-life is important because I'll use it in one of the cases later on this presentation. So if you look here, for DABA it is approximately 13 hours. Here 12 hours. So it is almostly for these three drugs 12 hours. And this is the rate of elimination. For here in urine, 75% in urine for dapagliflozin, 52% in feces with feces in canagliflozin, and for IMBA 40% within feces and 54% within urine. So all these are pharmacokinetics aspects of different members within this class. Regarding the specificity for sodium glucose cotransporter 2 inhibitors, this is a rat experimental model using PET scan with dapagliflozin. So it is FDAPA. Here, this is the wild rats. If you look here, dapagliflozin is taken by the kidney. But here, if there is a knockout for sodium glucose cotransporter 2 inhibitors, sodium glucose cotransporter receptors, so there is no receptors, so there is no uptake of GABA. Here it is the rat is knocked out for sodium glucose cotransporter 1 and 2. Again, there is no uptake of GABA. But here the rat is knocked out for sodium glucose cotransporter 1 only. It is the same like wild type. This means that dapagliflozin binds only the sodium glucose cotransporter 2 within the kidney. And this is the histological view showing that the sodium glucose cotransporter 2 inhibitors are within the proximal convolute tubule segments. Regarding the use, we have the prescribing information within the United States label here for the most commonly used three drugs, canagliflozin, dapagliflozin, and empagliflozin within the United States. Before using them, we should assess renal function prior to initiating sodium glucose cotransporter 2 inhibitor treatment, and periodically thereafter. So this is the advice. For canagliflozin, dose adjustment and more frequent renal function monitoring are recommended in patients with estimated GFR less than 60 ml per minute per 1.73 square meter. Limit the dose of canagliflozin to 100 mg once daily in patients with moderate renal impairment, estimated GFR between 45 to 60 ml per minute. Canagliflozin shouldn't be initiated in patients with estimated GFR less than 45 ml per minute. This means stage 3B chronic kidney disease. Canagliflozin is not recommended when GFR, estimated GFR by a formula, is persistently less than 45 milli per minute. So this is a very important point. Sodium glucose cotransporter 2 inhibitors are contraindicated in patients with severe renal impairment, estimated GFR is less than 30 milli per minute, or patients with end-stage renal disease or on dialysis. So we should put all these points in our mind. For dapagliflozin, there is no dose adjustment if the estimated GFR is above or equal 60 milli per minute. DAPA shouldn't be initiated if estimated GFR less than 60 milli per minute. DAPA is not recommended in patients with an estimated GFR persistently between 30 and 60 milli per minute. Again, it shouldn't be given if the estimated GFR is less than 30 because it is contraindicated. For empagliflozin, no dose adjustment if estimated GFR is above 45 milli per minute. EMPA shouldn't be initiated in patients with an estimated GFR less than 45. Discontinue EMPA if estimated GFR is persistently less than 45. Don't initiate at all if estimated GFR is less than 30 milli per minute. This is regarding the prescribing information within the United States. What about Europe? The same, assess renal function prior initiating this class of drugs, and prior to initiating concomitant medication. This is an important point that may reduce kidney function like ACE inhibitors, etc. And at least 2 to 4 times per year for renal function approaching moderate renal impairment. So we should put all this in our mind because this is how to use the drug safely. Efficacy of sodium glucose cotransporter inhibitor is dependent upon renal function efficiency, and this is a logic. No dose adjustment for canagliflozin if estimated GFR is less than is between 60 to 90. Canagliflozin shouldn't be initiated if estimated GFR is less than 60. In patient tolerating canagliflozin with estimating GFR less than 60 or creatinine clearance is less than 60, those should be adjusted only and maintained to 100 milligram once daily. Cana shouldn't be used in patients with estimated GFR less than 45. Cana should be discontinued if estimated GFR is persistently less than 45 milli per minute. So we should put all this in our mind. Regarding dapagliflozin, no dose adjustment is indicated if the estimated GFR is above or equals 60 milli per minute. DAPA is not recommended for use in patients with moderate to severe renal impairment. This means estimated GFR less than 60 milli per minute. DAPA should be discontinued if estimated GFR is less than 60 milli per minute. For empagliflozin, no dose adjustment if estimated GFR is between this range is above 60 milli per minute. EMPA shouldn't be initiated in patients with estimated GFR less than 60. In patients tolerating EMPA with estimated GFR less than 60 or creatinine clearance is less than 60, those should be adjusted or maintained at 10 milligram. This is the lower strength of the class. EMPA should be discontinued when estimated GFR is persistently less than 45 milli per minute or creatinine clearance is less than 45 milli per minute. And don't forget that all sodium glucose cotransporter 2 inhibitors are not used in patients with end stage or on dialysis, and when estimated GFR is less than 30 milli per minute. So we should put all these in our mind when we prescribe the drugs. Regarding the impact of chronic kidney disease stage on the drug efficacy, pharmacodynamic interaction. If you look here, this is A1C reduction by the use of sodium glucose cotransporter 2 inhibitor, DAPA, gliflozin 10 milligram once daily. If we are dealing with a patient with normal GFR, estimated GFR is above 90 milli per minute. Here, this is the reduction of A1C. But if it is between 60 and 90, it is the state of reduction. But look here, when there is drastic reduction of estimated GFR, here the efficacy of the drug is drastically reduced by the presence of this stage of chronic kidney disease. So in advanced chronic kidney disease, the drug is not working effectively, and we may have side effects. So this is why less than 60 ml per minute dapagliflozin is not recommended, and it's contraindicated if estimated GFR is very low. So what about the mechanism of action? If we look at the glucose homeostasis, here this is the amount of glucose that is filtered per day. 180 grams per day is filtered through glomerular filtration rate. Then the function of the tubules are very smart to deal with the filtrate. So in a normal situation, if serum glucose or plasma glucose is within normal range, proximal convoluted tubules reabsorb all the amount of glucose filtered per day. This is by the help of sodium glucose cotransporter present within the proximal convoluted tubule. We have early part of proximal convoluted tubule where sodium glucose cotransporter 2 type is present and is responsible about reabsorption of 90% of filtered glucose. In the late segment of proximal convoluted tubules, we have sodium glucose cotransporter 1, which is responsible about the reabsorption of 10% of glucose. So we have two types of cotransporters within the proximal convoluted tubule. Receptor type 2, which is responsible about 90%, and one which is responsible about 10%. In normal situation, no glucose coming to the urine because all filtered glucose is absorbed through the proximal convoluted tubule. So this is the situation. If we have, this is the filter. So here the filter includes glucose and sodium. Everything is sodium and glucose are absorbed. So there is within a normal situation, all glucose is absorbed, and some of sodium reaches this segment of the macula densa. So here sodium concentration is within normal, in a normal situation. So tubular feedback is normal. The presence of tubular feedback controls efferent diameter. So in normal situation, we have normal efferent and normal efferent diameters. So usually efferent is little bit narrowed in comparison to efferent to maintain hydrostatic pressure and keeping the GFR within normal. What happens in diabetes? Here in diabetes, the problem is the absorption. Yes, we have hyperglycemia, and the filtrate includes high glucose in comparison to the normal situation, but the problem is within the proximal convoluted tubule. The cotransporters for glucose are increased in diabetes. So reabsorption of glucose is increased. And with glucose, sodium also reabsorption is increased. So what happens? What happens is afferent dilatation. If you compare this with that, here the afferent is dilated. Sodium reaching the macula densa will be reduced. This will impair and decrease tubulo-glomerular feedback. And through different mechanisms, including angiotensin II, efferent is maximally vasoconstricted. So if you compare vessels here within the normal, afferent is dilated, efferent is more and more vasoconstricted. So the pressure within the glomerulus is increased, leading to hyperfiltration and increasing the function of nephron to work maximally. So this one of the problem is increasing sodium and glucose reabsorption within the proximal convoluted tubule. Why glucose is the reabsorption of glucose is increased? Because the cotransporters are expressed higher in type 2 diabetes. This means that kidney is one of the pathophysiological mechanisms of type 2 diabetes, and this paves the way for the class of sodium glucose cotransporter 2 inhibitors to reduce glucose reabsorption. So if we look at these vessels, yes, we have efferent vasoconstriction that may be ameliorated by angiotensin 2 pathways, either using angiotensin converting enzyme inhibitors or angiotensin receptor blockers, but it will not affect the afferent vasodilatation. The only drugs that may ameliorate both of these, I think it is sodium glucose cotransporter 2 inhibitors, because when we use sodium glucose cotransporter 2 inhibitor in type 2 diabetes, it will reduce the capacity of proximal convoluted tubule to reabsorb both glucose and sodium. So at the end of the day, sodium will reach in a normal amount to the macula densa, so it will improve tubuloglobal feedback, leading to efferent releasing of efferent spasm here. So at the end of the day, we will find normalization and restoring the filtration pressure and reducing hyperfiltration injury within type 2 diabetes. This is a cartoon that shows what I mentioned. This is a normal situation. Here is the expression of sodium glucose cotransporter. So both glucose and sodium are absorbed from the lumen toward the cell to be reabsorbed later to the blood. In the early part of the proximal convoluted tubule, sodium glucose cotransporter 2 is present, and in the late segment, sodium glucose cotransporter 1 is present. What happened here in type 2 diabetes? This is the expression of sodium glucose cotransporter 2. It is increased. So it will increase the reabsorption of glucose. So the price is development of hyperglycemia with all the consequences of hyperglycemia-induced inflammation and toxicities. So this is, and here I wanted to say that the threshold of reabsorption, the threshold of glucosuria, is readjusted by the use of sodium glucose cotransporter 2 inhibitor, because in type 2 diabetes there is increasing sodium glucose cotransporter 2 expression that will increase reabsorption. So glucosuria will appear in a state of hyperglycemia. So instead of glucosuria threshold is 180 milligram per deciliter in normal situation, it may be shifted to 200 or 250 milligram in type 2 diabetes. This is why sodium glucose cotransporter 2 expression is increased, reabsorption of glucose is increased within the nephron and the proximal convoluted tubule specifically. In heart failure, here you can find the different mechanism of actions. Here, enhanced macula densa chloride presentation, because here when we when the sodium and glucose reabsorption is reduced in the proximal convoluted tubule, so sodium and chloride will reach the macula densa, so it is enhanced. This will restore tubuloglobal feedback, release afferent, lead to afferent arterial vasoconstriction and reduction of intraglomerular hypertension with consequent long-term renal function preservation, and altered volume set point, reduction of subclinical congestion, reduced risk of acute decompensating heart failure, reduced risk of ventricular tachycardia and ventricular fibrillation, and I will mention the issue of ventricular arrhythmia later on. Improved renal EPO production, improved oxygen transport, improvement functional status, enhanced tubular flow, and diminished proximal sodium avidity and absorption, increased natriuresis, reduced the risk of advanced acute decompensating heart failure, and other mechanisms leading to reduce the risk and worsening of heart failure through reduced total body sodium content. Glycosuria lead to mild ketosis, and mild ketosis will improve cardiac metabolism, reduce risk of worsening heart failure. So all these are mechanisms related to the action of sodium glucose cotransporter 2 inhibitors in heart failure. So if we look at the class action in a panoramic view, I explained all the actions within the kidney and the proximal convoluted tubule, and this is the action on blood: decreasing blood glucose, decreasing plasma volume, decreasing blood pressure, decreasing arterial stiffness, decreasing cardiovascular events, decreasing heart failure, and on the pancreas, increasing beta cell function, increased glucagon secretion. So this is an important point because there are some adverse effects because of release of glucagon within the pancreas. It may be direct effect on the alpha cell or through other mechanism like overexpression of sodium glucose transporter 1 as a consequent mechanism that increases glucagon secretions, and I'll explain it in one of the slides. And this is the action on the muscles, increasing insulin sensitivity, and on the liver, increasing glucagon from pancreas will lead to increasing glucogenesis by liver, and this is one of the important points. So if we look panoramic to the actions, a lot of beneficial effects, but we think that increasing glucagon has some hazards. So this is why there is a disparity between sodium glucose cotransporter 2 inhibitors and incretin mimetics or DPP4 inhibitors. So both incretin mimetics and DPP4 inhibitors reduce glucagon. So this is why we can combine one of these drugs, either incretin mimetic or DPP4 inhibitors, with sodium glucose cotransporter 2 inhibitor to suppress glucagon release. And this is why this saxagliptin and dapagliflozin, this combination, in fixed dose combination of saxa as a DPP4 inhibitor and dapa as sodium glucose cotransporter 2 inhibitor with once daily oral administration, the fixed dose combination is bioequivalent to free combination of the mono components. Free combination of saxa and dapagliflozin and metformin improve the glycemic control to a greater degree than saxa and metformin or dapa and metformin in patients with type 2 diabetes, and inadequate glycemic control on metformin monotherapy or metformin plus one of the mono components. Associated with decreased body weight, generally well tolerated. So this is why there is a rationale for the use of combination of SGLT2 inhibitors with the DPP4 inhibitors. What about hypomagnesemia? What's your expectation? Does hypomagnesemia worsen after the use of sodium glucose cotransporter 2 inhibitors? This is the answer from this study is no. The use of the sodium glucose cotransporter 2 inhibitors improves significantly the values of hypomagnesemia. So here the magnesium increases by this percentage in comparison to placebo in the presence of hypomagnesemia. The question why? It is maybe because sodium glucose cotransporter improves insulin sensitivity, or stimulation of glucagon may increase magnesium reabsorption within the distal convoluted tubule. So this is one of the mechanisms, and not from bone, because using studies that address the bone showed no significant change in the bone by the use of sodium glucose cotransporter 2 inhibitors. Regarding the nephrology aspects, these are the different trials that addressed the sodium glucose cotransporter 2 inhibitor within the kidney and within other cardiovascular system. So this is EMPIRIC outcome trial, which was published in 2015 and showed a significant nephroprotection. This is a Canvas project, including Canvas and Canvas R, Credence, and this is the here. This is the will be published in 2019, and this is the Declare TIMI that included 17,000 patients, and we are waiting the result of this study in 2019 by looking at DAPA versus placebo, and here this is another study. So if we look here from the nephrologist point, this is an experimental work here in animal models and animal studies. The use of sodium glucose cotransporter 2 inhibitors, either IMBA or DAPA. Here you can find the effect on the albuminuria. Here the duration of action, duration of drug, and this is the animal model they used, and this is the effect on albuminuria. And the other nephroprotective effect is reducing kidney growth and inflammation, and decrease mesangial expansion and interstitial fibrosis. So a lot of effects are expected from this class within the experimental animal. What about the human trials? This is one of the trials, IMBA-REG outcome study trial, empagliflozin and the progression of kidney disease and type 2 diabetes, that was published in 2016. And this study showed that in comparison to placebo, this is the number of patients included either in the IMBA or placebo. Here you can find the cumulative probabilities of events. Here, incident or worsening nephropathy is significantly reduced with the use of empagliflozin. And this is the composite outcome is reduced significantly with the use of empagliflozin. So incident to worsening nephropathy or cardiovascular death is reduced significantly with the use of EMBA. Incident to worsening nephropathy, progression to macroalbuminuria, doubling creatinine, initiation of renal replacement therapy, doubling of creatinine, initiation of renal replacement therapy, or death. All these factors are reduced within the drug used. So this study and this trial showed that these drugs are nephroprotective. And this is another study, although a small study, included here 483 in this arm and 485 in this arm for the overall population. But for patients with urinary albumin creatinine ratio exceeding 30 milligram per gram, here the number of patients 76 and 78, so the sample size is not big. And if you look here, the using of either 100 milligram or 300 milligram canagliflozin is associated with preservation of GFR in comparison to glimepiride. So this means that for overall population, the GFR is preserved with the canagliflozin. And here, for patients with urinary albumin creatinine ratio exceeding 30 milligram per gram, here you can find the GFR is preserved with canagliflozin in comparison to glimepiride. Another study, which the bigger study, is canagliflozin and cardiovascular and renal events in type 2 diabetes. This CANVAS are the total, the project of CANVA, a total of 667 centers in 30 countries, and this is the program of CANVA. The CANVAS program comprised two trials: canagliflozin cardiovascular assessment study, which is CANVAS, and the CANVAS are canagliflozin cardiovascular assessment study renal. So the total number of patients included within the program is here, as you see, 10,142 type 2 diabetes with high cardiovascular risk factors. The patients were randomized to two groups, canagliflozin and placebo. And here you can find that the use of canagliflozin is associated with significant reduction of glycated hemoglobin, with reduction of body weight, reduction of systolic and diastolic blood pressure. Here the outcome, hospitalization for heart failure, progression of albuminuria. So here the advantage is clear. The use of canagliflozin as a member of sodium glucose transporter 2 inhibitor was associated with better kidney function. And here you can look at death from cardiovascular causes, here significantly better within the canagliflozin. And here you can find the death from cardiovascular or hospitalization for heart failure is significantly reduced. Progression of albuminuria is significantly reduced. 40% reduction in estimated GFR or renal death. This means need for renal replacement therapy is significantly reduced by sodium glucose transporter 2 inhibitor canagliflozin. Regarding the issue of combination of the use of sodium glucose transporter 2 inhibitor with other drugs, either antidiabetics or non-antidiabetics. So here, if we use sodium glucose transporter 2 inhibitors with angiotensin converting enzyme inhibitor or angiotensin receptor blocker, if we use them properly by looking at the dehydration is if present, we shouldn't use this combination. If there is diuretics, we should withdraw diuretics before this combination, and we should monitor kidney function frequently. If we use these precautions and using both classes of drugs, the mechanism will be the using of them. So this is the actions of sodium glucose cotransporter 2 inhibitors, reducing glucose reabsorption, so sodium delivery to macula densa, and the tubular glomerular feedback will be adjusted. Inflammations and others are adjusted. So at the end of the day, you will find nephroprotection. And the use of ACE inhibitor and ARBs here added their effects, activation added their effects on the hemodynamics. So at the end of the day, you will find both cardiac and renal benefits through this combination therapy in diabetic kidney disease. Has potential advantages of renal protection and the cardiovascular safety. Don't forget to use this combination. We should monitor kidney function proper, and we should look at the use of the diuretics. So it's better not to use diuretics with this combination. And if any diuretic is added or the drug dose is increased, we should recheck kidney functions. In combination with sodium with DPP-4 inhibitors, as you see here, the DPP-4 inhibitor will reduce the glucagon, stimulated glucagon secretion by sodium glucose cotransporter 2 inhibitors. So combining the actions of DPP-4 inhibitors with sodium glucose cotransporter 2 inhibitor will find at the end of the day improvement of the kidney. So this combination is beneficial with nephroprotection and the cardiovascular safety. Using glucagon-like peptide 1 receptor agonist with sodium glucose cotransporter 2 inhibitor, the same with increasing the potential of nephroprotection. So this means that these drugs can be used safely in combination with other drugs to protect the kidney and the heart. This is the effect of sodium glucose cotransporter 2 inhibitor in renal function and albuminuria in patients with type 2 diabetes, a systemic review and meta-analysis showing this is a meta-analysis for 47 studies that included 22,000 participants, and the conclusion: the use of sodium glucose cotransporter inhibition was not associated with significant change in estimated GFR to assure the safety of the use of this drug on kidney in patients with type 2 diabetes, likely resulting from a mixture. So early you may find some drop in GFR. This is acute effect, but on long term you can find the preservation. It seems like the use of ACE inhibitors. So sodium glucose cotransporter 2 inhibition was not associated with significant changes in estimated GFR in patients with type 2 diabetes, likely resulting from a mixture of an initial reduction of estimated GFR and the long-term renal function preservation of GFR. Sodium glucose cotransporter inhibition was associated with statistically significant albuminuria reduction in type 2 diabetes patients with diabetic kidney disease. This is a very interesting comments about the study published by Tong et al. About sodium glucose cotransporter 2 inhibitors and the risk of adverse renal outcomes among different drugs by using network meta-analysis. Network meta-analysis, there is some problem with the use of network meta-analysis, because in the conclusion that some members of the class may worsen kidney function. I think it is class effect, but the problem is you may find in the trial, for example, doubling of creatinine. So if there is kidney dysfunction but doesn't reach to doubling of creatinine, it will not be recorded. So the difference in estimation of the parameters and outcome may be a part of explanation of the difference. So at the end of the day, up to this moment, it seemed that there is no specific difference between the members within this class, but it may be a class effect on the kidney function. This is the most plausible. This is one of the reviews that discussed the issue of dapagliflozin. It's better to be explored. Regarding the anti-albumuric effect, although this study included 33 patients, but I found the idea behind is interesting. The albuminuria lowering response to dapagliflozin is variable, but the most important point, it is reproducible. What's meant? So if you give dapagliflozin for a patient, it may lead to a reduction of albuminuria in one patient and may not in other patient. So if in comparison to placebo, dapagliflozin significantly reduced 24-hour albuminuria and first morning albumin creatinine ratio. The most important, this is the design of the study. In the presence of DABA, here we find the reduction of albuminuria. And the washout period, albuminuria is again the same. And then when DABA is introduced in the second phase, so long as the patient responded in the first phase, the patient will respond again. So the response, initial response, the first response for albuminuria, this is albuminuria reduction within the first exposure, predicts the next response when the patient will be exposed. This paves the way for personalized medicine. So if we give dapagliflozin for a patient, the patient responded, and even if there is some interruption of the drugs, if we use it again, it will give the response for the same patient. And if it is given to a patient and there is no response, we will predict that the response in the second time of exposure will be the same, no response. So the response, anti-albumuric effect within the first exposure predict the response, and this is one of the personalized medicine. And more interesting that even the use of 6 weeks treatment with DABA 10 milligram per day, this is analyzed post hoc, the individual albuminuria response to RAS inhibitors and with addition of DABA. Here they didn't correlate the response to albuminuria in the first exposure to the second exposure of dapagliflozin, but they correlate the response of albuminuria to DABA from the response to RAS blockers, either S inhibitors or ARBs. This is ARBs and this is inhibitor. If you look here, the response to RAS blocker is the same like response to dapagliflozin. Can we use, so long as sodium glucose transporter 2 inhibitor may be beneficial by readjusting hyperfiltration and reducing inflammation within the kidney, can we use them for non-diabetic kidney disease? This is one of the experimental studies. This is CKD in mice fed on high oxalate diet for 14 days to create chronic kidney disease by oxalate. The use of empagliflozin in this study revealed no significant difference, no improvement in fibrosis in this scenario. But it seemed that we can use the sodium glucose cotransporter 2 inhibitors. Here, this is still diabetic kidney disease, diabetic nephropathy, and nephrotic syndrome, and the use of sodium glucose cotransporter 2 gliflozin was successful in reducing proteinuria. And this is a very interesting review about the effects of sodium glucose cotransporter 2 inhibitors in patients with diabetes given insight into potential use in non-diabetic kidney disease. And after thorough discussion, this is the expected mechanism. If this is the action of sodium glucose cotransporter 2 inhibitor that we discussed together through increasing glucosuria because they are glucoretics and natriuretic because they are natriuretic, at the end of the day, we'll find the renal protection and decreasing hyperfiltration. And this may be protective, especially in obesity-related chronic kidney disease, FSGS-related, and IgA nephropathy, because all these are non-diabetic kidney disease with hyperfiltration. So, by using sodium glucose cotransporter 2 inhibitor, we will modulate the intraglomeralular hyperfiltration, leading to adjustment of hyperfiltration. And this is one of the trials, Translate, treating to reduce albuminuria and normalize hemodynamic function in focal sclerosis with dapagliflozin trial effect. So it is Translate, and you are waiting the result of this study. Regarding metabolic aspects of sodium glucose cotransporter 2 inhibitor, what's meant by KGA1C paradox? KGA1C paradox, it is a paradox that is already known in diabetes management. If you use a drug that is potent and effective in reducing hemoglobin A1C, the only problem, one of the main problem is that this drug will increase the weight gain, like sulfonylurea. So, but here in sodium glucose cotransporter 2 inhibitors may be a weapon against this paradox, because this class of drugs reduce A1C and reduce body weight too. So this paradox is not present with sodium glucose cotransporter 2 inhibitor. This is one of the studies showing that the drug is effective in reducing hemoglobin A1C and in the same moment reducing body weight and blood pressure. So this drug will reduce the body weight, and this is the predictive for reducing body weight 3% and 5%. Another advantage is the use of sodium glucose cotransporter 2 inhibitors reduce the abdominal visceral fat area and may influence the renal function in patients with type 2 diabetes and protect the kidney. Another study, the combination with metformin, long-term efficacy and safety of sodium glucose cotransporter 2 inhibitor as add-on to metformin treatment in the management of type 2 diabetes. This is a meta-analysis. If you look here, after this period of time, after 52 weeks, you can find here significant reduction in A1C, and in the longer duration, 104 weeks, the effect on A1C is more prominent with the use of sodium glucose cotransporter 2 inhibitor. So adding sodium glucose cotransporter 2 inhibitor to metformin increases the efficacy. Here, the change of body weight from the early beginning, the use of sodium glucose cotransporter 2 inhibitors reduced the body weight significantly, reduced fat significantly, and with lower risk of hypoglycemia. So all these are advantages from the metabolic point of view. And this study showed the longest term efficacy up to this moment at the review for 4 years. Efficacy showing that the response to sodium glucose cotransporter dapagliflozin is durable. And this study suggests a favorable safety profile and sustained efficacy up to 4 years. This is an interesting study because if we calculate the amount of glucose within the urine through glucolytic effect of sodium glucose cotransporter 2 inhibitors, we can expect that the patient will lose some of kilograms. But when we apply in the real practice, we'll find there is a gap. So the reduction is not like what's expected. So this study is a complex study looking at this concept because this is the design. Through this design, there is a measurement of energy expenditure and measurement of appetite by functional MRI and the liver fat by MRS. So all these parameters will assess the diet, the appetite to diet, the energy utilization, and explain the gap between the expected and the real loss of body weight within the use, after the use of sodium glucose cotransporter 2 inhibitors. Regarding the comparison of different kinds of sodium glucose cotransporters, 6 drugs, this is from the metabolic point of view. Here, this practice, if you find the arrow like this means that the p-value is significant. But if you find the arrow between brackets, this means that the p-value is insignificant. So if you fix this table and look at sodium glucose cotransporter 2 inhibitor in general, or the different members, TOFO, CANA, IMBA, IBRA, DABA, LISO. If you fix the slide and look at body weights, systolic blood pressure, diastolic blood pressure, plasma glucose, A1C, AST, LT, GGT, uric acid, triglycerides, HDL, LDL, non-HDL, you'll find that sodium glucose cotransporter 2 inhibitors are either metabolically friends or it doesn't affect it adversely. So either they are beneficial or doesn't lead to any change. So this means that the use of sodium glucose cotransporter 2 inhibitors in the metabolic profiles are friends and are beneficial. Another concept which is very, very interesting for me. Yes, we are afraid of urinary tract infection or genital infection by increasing glucose in urine. But what about the airway? Increasing airway glucose in diabetes increases infection. And this is why if we succeed to reduce glucose in the airway, this will reduce infections. And I think sodium glucose cotransporter 2 inhibitor, by their unique action, it can lead to decreasing airway glucose because they increase glucose within the urinary tract. This may be beneficial for patients with pulmonary infections. This is a protocol for the use of sodium glucose cotransporter 2 inhibitors, dapagliflozin, for the management of pre-diabetes. Pre-diabetes in this trial means A1C is between 5.7% to 6.4%. And this study addressed the issue of the use of either sodium glucose cotransporter 2 inhibitors, metformin, exercise, body or lifestyle on the body composition and the cardiovascular risk in patients with pre-diabetes, and this is the protocol, and we are waiting the results of the use of sodium glucose cotransporter 2 inhibitors in pre-diabetes. In type 1 diabetes, in my previous video about sodium glucose cotransporter 2 inhibitor on last March, I mentioned that these drugs shouldn't be used in type 1 diabetes, and I presented a case of mesenteric ischemia and resection and stenosis of the intestine because of the adding sodium glucose cotransporter 2 inhibitor to insulin. However, there is accumulating some papers about the use, the rationale beyond the use of sodium glucose cotransporter 2 inhibitor in type 1 diabetes, although the number of patients are still small, but it seems that using sodium glucose cotransporter 2 inhibitor by their unique mechanism plus insulin may be of value, and so are waiting the further studies. And this is a study for the use of sodium glucose cotransporter 2 inhibitors, dapagliflozin, for the management of non-alcoholic steatohepatitis, although the study included few number of patients, but we are waiting the result of these drugs. Regarding cardiovascular system, what are the advantages? One of the studies addressed this issue is CVD real trial or study. It is not a randomized control trial. It looked at the all patients used sodium glucose cotransporter 2 inhibitors versus other non-sodium glucose cotransporter anti-diabetic drugs in 6 countries, including US and 5 European countries. And this is at the end, this is the number of patients in the sodium glucose cotransporter 2 inhibitor by propensity matching, 154,000 patients in this arm, and this is the other in the second arm. And the sodium glucose cotransporter inhibitor used in this 150,000 patients are distributed between canagliflozin 53%, dapagliflozin 42%, and IMBA 5%. What are the main results? Here, the outcome for hospitalization for heart failure, all cause deaths, and hospitalization for heart failure or all cause deaths for sodium glucose cotransporter inhibitors versus other anti-diabetic drug treatment. Here you can find in United States there is significant reduction of hospitalization for heart failure, all cause deaths, hospitalization or all cause deaths. All these are beneficial, are significantly reduced with the use of sodium glucose cotransporter 2 inhibitor within the United States, and within the 5 and the European countries, the same reduction of hospitalization for heart failure, reduction of all-cause death, hospitalization for heart failure. And the main conclusion, the lower rate of hospitalization for heart failure and death associated with sodium glucose cotransporter 2 inhibitor treatments appear likely class related, and there was no significant heterogeneity across countries despite geographic variation in the use of specific sodium glucose cotransporter 2 inhibitor. 76% canagliflozin in the United States and 92% dapagliflozin in Europe. And this is one of the poster presentation that was presented at the European Society of Cardiology Heart Failure meeting on April 29 to May 2nd of 2017 in Paris. And this is dapagliflozin is associated with lower risk of hospitalization for heart failure, major adverse cardiovascular events, and all-cause deaths compared to DPP-4 inhibitor in type 2 diabetes. So it is CVD real Nordic. So the data sourced from Norway and Sweden. All patients with type 2 diabetes dispensed with sodium glucose cotransporter lowering drug between 2013 and 2016. New users were defined as those with no prescription of the drug of interest within a year of the index date. And here you can find the major response. Here you can find significant reduction of hospitalization for heart failure, major adverse cardiovascular events, and all-cause deaths. All these are reduced by the use of dapagliflozin in comparison to the other class. Regarding this is another study showing the addressed the 73 randomized control trial, and the number of patients in these trials was 100,000 patients. So this is a network meta-analysis comparing the effectiveness of oral anti-diabetic drugs in preventing cardiovascular mortality and morbidity. Here, if we look here, this is a network and pairwise meta-analysis of all-cause mortality of oral anti-diabetic drugs. If we look at sodium glucose cotransporter 2 inhibitor, it significantly reduced this outcome, which is all-cause mortality, in comparison to DPP-4 inhibitors, and significantly reduced in comparison to TZDs, and the same with sulfonylurea. Insignificant difference with metformin, and it is superior to placebo. So sodium glucose cotransporter 2 inhibitor is more beneficial and is superior to all these classes, or to DPP-4 inhibitors, to TZDs, sulfonylurea, and placebo. And there is insignificant difference with metformin regarding all-cause mortality. And if we look here, this is regarding the network meta-analysis for cardiovascular-related mortality. Again, sodium glucose cotransporter 2 inhibitors are superior to DPP-4 inhibitor, to ZDs, and sulfonylurea, and placebo. But there is no significant difference in comparison to metformin. Again, this is the network and the pairwise meta-analysis for acute coronary syndrome. Here, the use of sodium glucose cotransporter 2 inhibitors is significantly superior to the DPP-4 inhibitor, to these sulfonylureas, and here metformin and placebo. So it seems that sodium glucose cotransporter 2 inhibitors are advantageous for the use against the cardiovascular problems. This is an interesting study, also included a few number of patients, but dapagliflozin as add-on therapy to metformin for 16 weeks improved the endothelial function in type 2 diabetes as evaluated by the flow-mediated dilatation by applying Doppler study and then releasing the cuff above systolic blood pressure for 5 minutes, and then releasing cuff and repeating the measurement of the brachial flow. So the flow-mediated dilatation is improved by the use of dapagliflozin. Regarding the ventricular arrhythmias and the ventricular repolarization, this study included this number of patients: 17 for EBRA, 16 DAPA, 7 EMBA, 3 CANA, and others. The most important point is the use of sodium glucose cotransporter 2 inhibitors improve the abnormality within QT interval and QT syndrome. So prolonged QT syndromes are ameliorated and improved by the use of sodium glucose cotransporter 2 inhibitors. So this may be a rationale behind their use. Regarding the cautions and safety, the most important point in this presentation is safety, how to use the drug safely. All these are positive effects that I mentioned through the presentation for the kidney, for the metabolic, for the heart, for everything. But regarding negative aspects, higher prevalence of urinary tract infection and genital infection, this is to put in mind. So if the patient has UTI, active UTI, it's better not to start with UTI. And if the patient is witnessing genital infection, it's better not to be given, especially in women. Increased osmotic diuresis, so it shouldn't be given for patient on active diuretics. Great precautions when used in patient with moderate to severe renal insufficiency. Increased risk of bone fracture, especially canagliflozin. A possible association between use and the occurrence of diabetic ketoacidosis, and I'll explain it later. Regarding this system, the side effects here, if you look, amputation is significantly higher with canagliflozin, and here fracture is significantly higher with canagliflozin. Infection of male genitalia, in osmotic diuresis, volume depletion, mycotic genital infection in women, all these are significantly higher with canagliflozin. Acute kidney injury is reported with sodium glucose cotransporter 2 inhibitors, and this may be due to osmotic shift, so it's better to monitor kidney function proper. Why there is kidney dysfunction and kidney harm? Because it may be due to uric acid crystal, because one of the action of the sodium glucose cotransporter 2 inhibitor is to increase uricosuric effect. or uric acid-induced oxidative stress and pro-inflammatory effects, or fructokinase-induced chemokines and oxidative stress, or medullary hypoxia. All these factors may be related to the issue of acute kidney injury induced by sodium glucose cotransporter 2 inhibitor. So the question is, when the point is, when we use this class, we should use them after assessing kidney function, evaluating to avoid use them in dehydration. This will antagonize the effects of the acute kidney injury. And this is the rationale of using biomarkers to address the site of toxicity of the drugs. Regarding the effects and possible risks to put in mind, sustained renal glycosuria, this may lead to urogenital infection, increased ketogenesis in predisposing condition, change in insulin glucagon ratio, and the possible risk of DKA in susceptible individual, and I'll explain DKA later on. Fluid balance, dehydration, volume depletion, again and again, hypotension, especially in elderly, and the risk of fall should be put in mind. So we shouldn't give the drug in the presence of manifest volume depletion. Electrolyte imbalance in susceptible individual, concomitant diuretic use will increase this risk. Renal impairment, including acute kidney injury in susceptible individual, dehydrated state, advanced chronic kidney disease. So, effect on renal, enhanced contribution of renal gluconeogenesis to blood glucose homeostasis, may increase plasma renal activity. Concomitant use with diuretic and dehydration increases risk. So, we should put in mind all these risk factors. Regarding the other actions, here hyperkalemia, no imbalance with DABA, higher imbalance with canagliflozin. Bone fracture, no imbalance, increased risk with canagliflozin. Risk of malignancy with DABA, here imbalance for bladder cancer. This is why an imbalance in bladder cancer was observed in clinical trials. Dapagliflozin shouldn't be used in patients with active bladder cancer and should be used with caution in patients with prior history of bladder cancer. All these are important point to put in mind. This is a very interesting case that was published in June 2017, the cause of American kidney disease. So this is a 65-year-old man with medical history of type 2 diabetes and hyperlipidemia was admitted to the hospital for elective surgery to resect an enlarged mucinous pancreatic cyst. His home medications included canagliflozin 300, rosuvastatin, and other drugs. The patient tolerated the procedure well and was transferred post-operative to surgical floor with unremarkable laboratory values. Once he was admitted to the hospital, all oral medications were discontinued, and this was his results. Everything is fine, and then after 4 days, the patients start to have acidosis. So bicarb is reduced to 13 to 8.5, and there is urine glucosuria, and there is ketones. So this is ketoacidosis, and the serum glucose is accepted 123. So this means euglycemic ketoacidosis. The why and how to manage. Why in this case the patient had this syndrome? So it is the syndrome of euglycemic ketoacidosis induced by the sodium glucose cotransporter 2 inhibitor. Why? Because reduce the insulin and increase the glucagon. This is the scenario with the use of sodium glucose cotransporter 2 inhibitor. Glucagon is increased either direct effect of sodium glucose cotransporter 2 expressed in pancreatic alpha cells, leading to increased ketogenesis. Lower insulin to glucagon ratio leads to nearly 40% higher lipolysis, 20% higher fat oxidation, 60% lower carbohydrate oxidation, 15% lower glycogen synthesis, and 2-fold higher ketogenesis. So especially with the presence of stressors like surgery in this case, other cases, alcohol consumption, pancreatitis, or severe injury. This is another study showed that dapagliflozin modulates glucagon secretion in sodium glucose cotransporter 2 independent manner in murine alpha cells. And the mechanism that was explored from this study is increasing the sodium glucose co-transporter 1 as a consequence of blocking 2, this is one of the mechanisms that stimulated glucagon in this study. Let us to go back to the case. So this is a case after 4 days from stopping canagliflozin, the patient developed euglycemic ketoacidosis. So what about the half-life of this canagliflozin? It's 12 hours, as I mentioned in the beginning of the presentation. So even after stopping the drug, its action may be maintained because we have glucosuria and ketosis. So glucosuria and ketosis referred to the action of this drug. So although the drug may be cleared from the plasma, but its action may be maintained for a period of time. So we should put it in our mind, especially in a patient exposed to stress like surgery, or the patient suffer from the problem from complications. So we should monitor the patient properly. So the treatment was stopping, giving IV insulin and glucose, IV glucose and insulin. On day 8, insulin was switched from IV to subcutaneous. What happens? What happens if you look here? The bicarb is reduced the next day from 22 to 16. This means that the action is still maintained. So again, they resumed IV insulin until 3 days later, everything is normalized. So this case gave us a hint about the maintained action of the drug even after its discontinuation, leading to ketoacidosis, and I explained why. Because of decreasing insulin and increasing glucagon, this will lead to increasing ketogenesis. So ketogenesis in the presence of sodium glucose cotransporter 2 inhibitor is explained by hyperketonemias induced by sodium glucose cotransporter blockade, results from enhanced ketogenesis. Here, this is a very interesting, address the FDA data for reports of euglycemic ketoacidosis. IMBA 46 case, DABA 144, CANA 450. The most important risk factor for development of euglycemic ketoacidosis after the use of sodium glucose cotransporter 2 inhibitor is the presence of very low level of C-peptide, because it reflects hypoinsulinemia. So if C-peptide is less than 1.1 nanogram per ml, this will increase the relative risk by 3 folds. But if the sodium, if it is between 1.1 and 4.2, treatment prior to sodium glucose cotransporter by insulin, it increases 2 folds. This means that the patient needs insulin. And if the treatment doesn't include insulin, it increases it by 1 fold. However, if C-peptide is above 4.2 and the treatment includes insulin, this increases the risk for 1. If there is no insulin, the risk for euglycemic is 0. So low C-peptide, especially with the statin and diuretics, may be a risk factor for development of ketoacidosis in these patients. Regarding infection, if you look here, there is no significant difference regarding the comparison of sodium glucose cotransporter 2 inhibitor, almost 2,000 case to 2,000 case of DB4 inhibitors. Here, UTI the same, no significant difference. But genital infections, including vulvovaginal infection, vaginal infection, balanitis, candidal balanitis, fungal balanitis, vulvovaginal candidiasis, genital candidiasis, vulvovaginitis, vaginal thrush, bacterial vaginitis, vulvitis, vulval abscess, all these are increased with the use of the this drug. And either unadjusted, it is 3.8 fold, or adjusted 3.5 folds. So although UTI is not increased in this report, but genital infections significantly increased by 3 folds. This another study addressed the ABCD, the Association of British Clinical Diabetologists, regarding the clinical risk factor predicting genital fungal infection with dapagliflozin. Here, if you look here, this is the demographic data. There is no significant difference between those who had genital infection or not. But female sex may be a risk factor. The previous genital infection may be a risk factor for less than 1 year. If the lessons from this audit is when the patient has a history of genital infection, especially a female, it's better not to use the drug or to give it cautiously for these patients. And if there is any urinary tract obstruction or increasing residual urine volume, this may be related, may be associated with increasing UTI as shown in this case report. And here, if we use sodium glucose transporter 2 inhibitor with metformin, here you can find the combination therapy are associated with increasing significantly the risk of genital tract infections. Another important point, the cost analysis. In comparison to the use of CANA, DABA, or IMPA are expensive drugs as monotherapy. So the most rational is, up to this moment, the most cost-effective treatment of type 2 diabetes starting is metformin. So we should start with metformin. Unless the patient is intolerating or there is contraindication for metformin, we can start with other drug. But up to this point, the cost effectiveness of the use of sodium glucose transporter is to add them. Yes, they can be used monotherapy or in combination, but it's better to use them as added on to metformin because of the expense of the cost. To conclude the presentation, I explained the unique action of sodium glucose transporter 2 inhibitors in type 2 diabetes to reduce the here the afferent dilatation will be reduced and efferent vasoconstriction will be released by the use of sodium glucose transporter 2 inhibitor to ameliorate the environment within diabetes. The most important points: prohibit the use of sodium glucose transporter 2 therapy in moderate to severe chronic kidney disease if estimated GFR is less than 45 ml/min, because the drug will be ineffective in this scenario and you will gain side effects. Pregnant and breastfeed women, risk is not known. For the treatment of diabetic ketoacidosis, not to be given. And acute stressful, catabolic stress like severe medical illness or surgical consideration. Observe the caution. So all these are contraindication for the use of sodium glucose transporter 2 inhibitors. Caution should be exerted in using them in risk of volume depletion, in frail elderly, with low diuretics, condition predisposed to dehydration or renal impairment, in combination with diuretics. Monitor fluid and electrolyte status, insulin and sulfonylurea to minimize hypoglycemic events. Complicated UTI, temporary discontinue is recommended. History of recurrent UTI or anatomical obstruction, the risk of UTI may increase. Condition of fasting, the risk of starvation and the precipitation of glycemic decay will increase. Patients with already elevated hematocrit, unapproved indication like weight loss, SIADH, heart failure, type 1 diabetes, pre-diabetic state, and the risk of benefits is still, we are waiting studies to address this issue. So the karma means the policy and ethics of the use of drug. And when the drug is used in a fantastic way, in the most safe way, this is a meta-analysis addressing the issue of ketoacidosis. Here, no difference. It seems that if the drug is used here with the comparison to others, if sodium glucose transporter 2 inhibitors are used in and their use is following the rules, the scientific and ethical rules, you will find the risk of euglycemic ketoacidosis negligible. I think this is the last slide. This is just to remind you by the different classes for the treatment of diabetes, because sodium glucose transporter 2 inhibitor are one class from many classes for management of diabetes. We have pancreatic beta cells, so dysfunction, so sulfonylurea and meglitinides, and we are in the future we are waiting the assessment of amyglinin. For pancreatic alpha cell, we have glucagon peptide 1 receptor agonist, and we are waiting if there will be approval of glucagon receptor antagonist. So these are the existing drugs, and this is the future for drugs that are expected to be present if they are proven in the studies. In creatine, GLP-1 and the DB4 inhibitors, and here oral GLP-1 receptor agonist once weekly DB4 inhibitors. For inflammations, here up to this point we have GLP-1 receptor agonist DB4 inhibitors, but we are waiting the validity of immune modulator and inflammatory agents. For liver, metformin and dapagliflozin reduce hepatic glucose output, and we are waiting the glucagon receptor antagonist. in the muscle, metformin and ibuglitazone reduce the peripheral glucose uptake. This is a pathophysiology that is ameliorated by metformin and ibuglitazone, insulin sensitizers, and selective PPAR modulators in the future. Adipose tissues, metformin and ibuglitazone, and we are waiting the evaluation of PPAR, FGF21 analogs fatty acid receptor agonist. For the kidney, sodium glucose cotransporter 2 inhibitors are approved, and we are waiting the combined inhibitors of sodium glucose cotransporter 1 and 2. For the brain, GLP-1 receptor agonist acts on appetite, and here GLP-1 glucagon gastric inhibitory peptide dual and triple therapy. The stomach or intestine, sodium glucose cotransporter 1 inhibitors are expected to be present, but nowadays we have GLP-1 receptor agonist, DB4 inhibitors, alpha glucosidase inhibitors, bramilinitide. For colon, metformin receptor GLP-1 DB4 inhibitors works on this issue of abnormal gut microbiome, and we are hoping in the near future to have probiotics. So we are waiting many advances, and one of the advances in sodium glucose cotransporter 2 inhibitor to have superior stable dapagliflozin. Here dapagliflozin citric acid crystal, this is DAPA and this is citric acid. If this will be showing better solid state properties than dapagliflozin. So because we are exhibiting superior stability against high temperature and high relative humidity. So we are waiting the further and further research. The last slide. This is the conclusion from any presentation. This is a statement of William Osler, the father of medicine. He who studies medicine without books, sails an uncharted sea. This means that he doesn't know where he is going. But he who studies medicine without patience doesn't go to sea at all. This means that he doesn't see at all. What does it mean? We should read and update ourselves and follow up the literatures, and we should work on patients to have experience. So learning and working with patients to have the knowledge and the experience, this is the medicine. Thank you very much for your attention. I'll be happy to receive your questions. Thank you.